some of you know, tonight we have Dr. Shereen Lim from Sparkle Dental presenting on tongue ties for us. Shereen is really passionate about myofunctional therapy, tongue ties obviously, and sleep dentistry. So please give her a warm welcome.
Thanks, Shereen. I really want to thank Life Care Dental for hosting me tonight and for Susan for encouraging me to do this presentation. My name is Shereen. Can you hear me okay? Yeah. And I am a general dentist in Joondalup, and I gave my first presentation for Life Care Dental probably about 2 or 3 years ago. It was on screening and the management, the dental professionals were on screening and management of pediatric sleep disordered breathing. And during that presentation, I actually did present some research about tongue tie and sleep apnea for about 10 minutes. But since then, it's been a huge learning journey. I've actually done a lot of courses on tongue tie and a lot of other courses on tongue function from various other professions, from lactation, speech, and sleep. And so what I do in the practice, I'm involved with tongue tie release for infants through to adults. I get a lot of referrals from all different sorts of health professionals, from lactation consultants, speech and feeding specialists, the sleep physicians, and also other dental professionals, so quite a few in the room today. And I do actually see patients from all over WA, so people fly in from Broome, they drive from Esperance, Kalgoorlie. So I actually get to see quite a number of different patients. And so I'm going to try and share some of my experience with you and discuss some of the research and what we do in that area. So what I'm going to cover with today's presentation is why I became involved in this area of tongue tie management and why I'm a passionate advocate for breastfeeding. I'm going to then talk about the implications, assessment and management during infancy. So share some speech and feeding discussion and case studies. What is the impact of tongue tie and orofacial and craniofacial development and OSA development? I'm going to talk about what is myofunctional therapy and what is the rationale for tongue tie release, as well as postural implications into adulthood. So I put together the presentation, finishing it up yesterday, and I only went through yesterday and thought I'm going to try to run through a bit of it, and it proved to be a little bit longer than I thought. I was given 90 minutes, and I'm just going to warn up front, I hope you can indulge me a little if I run a little bit over, maybe 10-15 minutes, because it's some information that I feel very passionate about sharing. So what is amphiglossia? It's a congenital condition where the lingual frenulum is unusually tight, short, thick, and it restricts the tongue's range of motion. So really important to distinguish tongue tie from lingual frenulum is that restriction of normal motion. And the incidence is reported in various studies between 0 to 0.1% to 10.7%, depending on the population. And one of the things that I believe is underestimated, because we don't really have a good tongue tie classification. So most of these studies are really looking at tongue ties all the way to the tip of the tongue. But we understand that if the attachment is tight further back, there may be some problems as well. So tongue ties are related to the failure of apoptosis, or normal cell program death, of the fibromucosal fold that connects the undersurface of the tongue to the floor of the mouth. So one of the things about tongue tie management is it's super controversial at the moment, so I'm sure a lot of people are familiar with all this controversy. And part of the reason is we don't really have some great evidence for it. When we're talking about evidence, there is a hierarchy of evidence where we have low-level evidence, such as case reports, and then we go up to case series where we're looking at multiple case reports, and we actually have to work our way up the ladder, slowly by slowly, to actually identify specific subgroups that we can study and look at closer associations before we get up to the real high-level studies, which are the randomized controlled trials. So that's when we take groups of people and decide some are going to have the tongue tie release and some aren't, and we're going to compare what the outcomes are. And so really when we do interventions that involve surgery, particularly on babies, we want to actually see this high level of evidence. But just because we don't have high level evidence, it doesn't mean there's no evidence. It just means we're slowly working up our way to understand these issues. So this is a paper that was published that actually shows that there's been a dramatic increase in tongue-tie related articles over the last 67 years. So there was approximately 514 midline registered articles. And what we can actually see is that there's been a very exponential increase in the last 10 years, very dramatic. And so what we found overall with the tongue-tie research, most of it is on the lower level of the hierarchy. It's case reports, series, editorials, opinions. But in the last 10 years, we've had a very good increase in quality studies. So we've had 8 randomized controlled trials, 10 systematic reviews. And so what the authors suggest that if this trend of high quality research keeps continuing, we're going to have really good, better understanding and be able to establish clearer guidelines on when to intervene, and then it will be less controversial. So we're working towards that. So how I got involved, I'm going to spend quite a bit of time discussing how I got involved because I do have a sleep perspective, and I think the ultimate goal of the tongue should be to actually suction in the roof of the mouth. And when it's suctioned in the roof of the mouth, it will promote normal palate development, and it's impossible to breathe through your mouth. It's going to promote the, mechanically more nasal breathing. So I got involved in sleep through my husband, Alex Javalaris, over there. His snoring was driving me totally crazy, and I understood that these dental sleep appliances were effective at reducing snoring. So I wanted to learn. I figured that more people might need help with their spouses. So I enrolled in this 2-year graduate diploma in dental sleep medicine. So that's where I became involved in dental sleep. And so I started getting all these referrals for these mass appliances and mandibular advancement devices. And it's really a rewarding area of dentistry to be involved in, because when we help people sleep better, it really improves their quality of life, their relationships, their mood, and really reduces serious health risk. But I did have a problem with it because I'm thinking these meds, the patients that I'm getting referred, they're not the obese individuals. The risk factor is clearly craniofacial. And we know that high arch palates and retrognathic mandibles are very known risk factors. So really we're doing a band-aid solution to deal with the poor anatomy. So what I was thinking is, how come we can't actually work on this when a child is still growing? Why can't we help them develop the proper skeletal structures? So this is the difference between having a high and narrow palate and a broad normal palate. The palate is actually the floor of the nose. So if we have a narrow constricted palate, by definition we're going to have a poorer nasal airway. And when we look at flow physics, what we know is flow through any tube is, if we have the radius of that, is exponential increase by 4 to the power of 4. So we can get very dramatic improvements in the nasal airflow just by doing a couple of 2-3 millimeters of palate expansion. The other problem that when we have this constriction in the palate is that we have a nasal septum, which is a cartilage, and it's a fixed size. So if we're trying to fit it in that smaller box, we're going to have more deaffiation, which is going to compound the problem of airflow flowing through the nose. There's actually quite a lot of research to support that if we do palate expansion in children, we're going to improve breathing outcomes. And the one study that I think I really want to share with this group is a Perth study, because it was one of the very first studies that actually people started recognizing that there was an impact on palate expansion and breathing. So it was published in an international ENT journal in 1975. It was the work of Dr. Philip Gray, an ENT, and also an orthodontist. And what they did was they documented 310 consecutive cases of rapid maxillary expansion for medical reasons. So it doesn't matter if you don't have a crossbite, they're going to do this for the purpose of remodeling the nasal airway. And for all these reasons that are medical related. And what they found is that close to 90% of these patients were able to convert from mouth to nose breathing, and therefore it is a comparatively simple conservative method of treating impaired nasal respiration. So I did a presentation a few years ago for the UWA dental alumni, and many of you may know retired pediatric dentist Peter Gregory. And he actually approached me at the end and he said, wow, that brought back a lot of memories, because he was a registrar in the 70s at the time these studies were being performed, and he was involved with actually removing all the palate expanders. So I asked him, you know what, this is so influential around the world, how come we're not doing it in Perth? And he actually explained to me that at the time, the orthodontist was considered a maverick. So that he was shunned by the whole orthodontic profession. So he felt it was a little bit of deja vu, and he basically encouraged me to keep spreading the word. So it was in the 2000s that people started looking and measuring what would happen if we did palate expansion on children with obstructive sleep apnea. And there's been so much research done on it. We've actually got several systematic reviews on it. And this is a particularly good one published in the Ringer-Scope, which shows us that we can get a consistent improvement with AHI and lowest oxygen saturation. Now, the secondary benefits of expanding the palate is that we can actually get an improved tongue posture. So the tongue can raise and create that suction, and as the tongue lifts and creates that suction and sits in the proper place, we get that increased volume for the tongue to fit. It's less likely to actually encroach on the posterior airway space, which is helpful during sleep when everything is more relaxed. So this is a really great research paper by, directed by one of my really good friends and colleagues from Standard Sleep, and it was only published this year. It's a really important one that I believe that any dentist involved in dental sleep medicine should be aware of. So what it shows us is that they looked at a group of people that had nasal surgery, and they worked out there's two groups. One is the people that responded to the nasal surgery, and the other people had persistent nasal obstruction. And they're trying to measure and work out what is the difference between these people. And what they found was that the people that had persistent nasal obstruction, they actually had a high arch palate. And so they suggested that these people may benefit from additional skeletal modelling procedures such as maxillary expansion. So we know in children it's really easy to expand the palate. The palate is really, the suture is not quite fused, and we can do that pretty reliably. But in adults it's a little bit more difficult as the suture expands. So I think probably the way that it's done here in Perth is they put, if we try to do it, it creates more dental tipping rather than actual skeletal remodeling. So in Perth they would probably do what's called SAMI, surgically assisted rapid maxillary expansion. They put an expander on their teeth, and then they do a surgery to split the suture and a very invasive cut, pterygoid disjunction, which is associated with increased risk of bleeding and that. But what some of the sleep researchers, including a friend Audrey Yoon, have been involved in is the micro-implant assisted expansion. So what they found is if you put these implants in very close to the mid-palate suture, you can actually reliably achieve expansion without doing the surgery to separate that suture. However, when a person gets to about the age of 25, it actually becomes a little bit unpredictable. It's not actually the resistance to that sutural separation in the mid-palate, but it's actually the zygomatic buttress of bone. So what these colleagues, Stanley Liu, Audrey Yoon, Christian Guilleneau did, they developed this protocol called DOME. So with DOME, this is the published report of the first 20 cases, but they've now done in excess of 100. What they do is they use the micro-implants to separate the suture, and also they do this cut, which is a lot easier than the actual traditional method. And they've actually shown it improves the nasal, remodels the nasal airway the best. And actually they've actually demonstrated that it reduces AHI or improves obstructive sleep apnea. So what happens is it gets about 0.25 millimeters of expansion a day. They can achieve about almost a centimeter within a month. And as soon as that is created, that separation, you can actually start doing orthodontic treatment. So this is one of the ones that they published. You can actually see on the scans that it's very reliable sutural separation, and also the closure with orthodontic treatment. And Audrey Yoon, she's a brilliant orthodontist. She often does this with Invisalign. So what we know is, I was actually at an international sleep surgery conference a few weeks ago. Maybe not so much in Perth, but in the international sleep surgery community. palate expansion in adults is actually really well recognized as a nasal surgery and an option for sleep apnea. So I believe that as dentists there needs to be more awareness of this, and we need to be working more closely with ENTs. So they've actually published in about 4 prominent ENT textbooks a chapter devoted to this thing. And so this technique is called dome distraction osteogenesis maxillary expansion, and I really love the creation of the name because what the idea is to take a Gothic shaped arch and to actually make it into a dome shape. So something nice and easy to remember. So I'm inspired by these guys. Dr. Christian Guilleminault, he's one of the fathers of sleep medicine, involved in the discovery of sleep apnea, as well as the palate expansion research and the tongue-tie research for sleep medicine. This is Dr. Audrey Yoon, the orthodontist that I was talking about, and Dr. Stanley Liu. He's an ENT and maxillofacial surgeon, so combined. If you are interested in dental sleep medicine, these are the 2 people that you need to hear. So Dr. Audrey Yoon, we brought out, I organised a conference in Melbourne in February. It's pretty well attended. It was a paediatric airway symposium, multidisciplinary. But what I'm doing next year in February, we're actually bringing out Dr. Liu, and this is one of the sleep physicians, rising stars in sleep medicine, that we're going to bring out for that event too. So February next year in Melbourne, and I'll be opening registrations pretty soon. So how does dome work to reduce sleep apnea? This is unpublished research, and it is due for publication shortly, but what they did, they used computational fluid dynamics to assess the flow of what's actually happening, and how does it actually reduce sleep apnea. So what happens when we actually do this palate expansion is we're remodeling the nasal airway, we're improving nasal ventilation or flow. And when we improve the nasal ventilation and reduce the resistance to breathing, so we sort of breathe easier, we're not creating those suction or the vacuum pressures that collapse the pharynx. And so when we can reduce the pressure, those closing pressures, we're going to reduce the AHI or sleep apnea. So it actually directly works. So if you saw one of the patients before, the photos, how we're doing a mandibular advancement device, but they had a very high arch palate, we can actually treat it more precisely if we actually do this palate expansion. And it's something that they, it's done. They don't have to comply with it for the rest of their life. So in sleep apnea surgery, probably in the ENT world and all that, there is what we call a standard surgery sleep protocol. It was developed 30 years ago by Riley and Powell. And what we know in sleep apnea surgery, maxillomandibular advancement or double jaw advancement surgery is actually the most successful surgery because it actually opens up the airways in many different levels. But it is a bit of an overkill or over-treatment. So the standard sleep surgery protocol is all about how can we address it stage 1 by looking at the nose, the tongue, the palate. How can we address those areas? Check the response before we go on to stage 2 surgery. So after 30 years, Dr. Stanley Liu, the one that I'm bringing out, he's actually published this year updated surgical algorithm. And there's been about 3 key changes, and the 2 that I want to mention to you tonight is number 1, when we're looking at the nose, we need to consider palate expansion. Number 2 is the tongue. So apart from tongue-based reduction and genioglossus advancement, trying to advance the tongue forward by moving that part of the geniotubercle forward, we also need to consider the function of the tongue. Alright, so we need to consider upper airway stimulation, which is also called hypoglossal nerve stimulation. This is when we send an electrical impulse to the tongue every time the airway is closing to actually protrude the tongue forward and stay out of the airway. And the other thing is myofunctional therapy. So myofunctional therapy, tongue exercises, they're designed to actually promote the tongue to palate suction, nasal breathing, and also improve the tone of the pharyngeal dilator muscles as well. So we know now that whatever surgery, whatever treatment that you do, it's important to address the function or the tongue function, otherwise you're going to get relapse. So this is a pretty big deal, and yeah. So what I really want everyone to take, going down this path is really that the high arch palate is an important phenotype in OSA that we as dentists are best positioned to recognize. And we've already got this evidence to suggest that if we can do it in children, it's going to improve their breathing. So I know that a lot of you guys will be in the same boat as me when we try to refer out, we can see they're developing malocclusion and we try to refer to the orthodontist. And usually the thing is, we'll just deal with it later. Let's monitor until growth is complete. I see you nodding there. And what I was finding was we were waiting, and then when they're ready, we're getting the referral back, why don't you extract these teeth, we're ready to start braces. And actually it really disturbed me because I've got children now and I didn't want my children to go down that path. So what I decided to do was learn more about orthodontics. And I just recognised Frank. Frank is an orthodontist, so I want to thank Frank for coming because it is difficult to have conversations with orthodontists sometimes. And Frank has been really open to learn more, and yeah, thanks very much for coming. All right, so I went and enrolled in the 2-year mini residency by Derek Mahoney, and yeah, he's really internationally known for teaching general dentists how to do early interceptive orthodontic treatments. And I was feeling pretty happy with it myself because now I'm going to be able to help children that need their palates expanded. And then at that time I was at a sleep meeting with Dr. Christian Gimeno, who I've shown you before. And I said, you know what, I ended up sitting next to him, so we had a good chat. And I said to him, your work's really inspired me to learn orthodontic treatment. And he just kind of, you know, so I said, what's the best palate expander design that you believe in, that you believe is best? And he said, if you're doing palate expansion, you're too late. So, you know, I was a bit confused by that. I had actually no idea what he meant at that time because I was pretty happy that I was going to be doing something positive. And what I now know is that when we have poor palate development, it's because we have some poor function, and that's created this. And if we can address that poor function very early on in life, when people are doing their most rapid growth, then you know, we can actually change their trajectory of development. And I think in dental school, I don't know if everyone else learned this, but this is something that I really remember, is we have this zone of equilibrium where the teeth tend to, and the alveolar bone tend to erupt in the neutral zone where the pressures of the tongue balance the inward pressures of the lips and cheeks. Yeah, so if we look at it from a different perspective, this is a picture, I think it's from Dr. John Liu. See in number 1, if we can get the tongue suction to the roof of the mouth, it will stimulate the suture and encourage the proper palate development. And really the palate should develop and house that tongue perfectly if the tongue is in that space. Very much like how the brain, the skull grows around the brain, the orbit grows around the eye. We want the palate to house the tongue perfectly. But if we look towards number 5, where the tongue is low, we can actually see there's nothing to support the palate and the inward pressures of the lips and the cheeks. So we have that high palate. And it could be related to a dummy, it could be related to chronic nasal obstruction and a low mouth open breathing, but it could also be related to the tongue tie. So Dr. Christian Gimeno, he published this paper last year. I think it's a fantastic review of all the evidence to support that if we have oral dysfunction, it's going to lead to abnormal facial development. So the key points in his paper is that obstructive sleep apnea is related to the abnormal collapse of the upper airway during sleep. The orofacial skeleton actually forms the support, so if we have any deficiencies in the growth of this skeleton, we're going to have increased collapsibility of the airway. So the peak development of the face, 60% is complete by the time of 6 years. So we want to address that early by addressing the dysfunctions early. So in the first year of life, we need a good suck, swallow and breathe coordination. So breastfeeding is really important with that. And then at 6 months, mastication is an added stimulus for growth. So we want to encourage textured foods and not overdo the purees or the city pouches and that type of thing. So, you know, we also know that there's quite a lot of evidence, and this is probably one of the higher level evidence papers that show us that if they do a meta-analysis and pool of studies, they can increase the power of the result. Looking at 30 studies, that actually showed us that we're going to have a reduced risk of malocclusion if children are being breastfed. They actually suggest that 6 months is protective, but if we can actually do 12 months, it actually has a better protective effect. But I will let you know that there is really good research to show that if we introduce a dummy, it actually negates that effect as well. So why is it protective? You know, if we encourage more breastfeeding, we're actually going to have less habits and sucking habits, which we also know are associated with malocclusion. But the muscular forces of breastfeeding is really important. It involves a lot more work than actually using a bottle. So it really works out those muscles that are important. And it also requires coordination of the nasal breathing and that. So we're going to get more nasal breathing and lip seal and that. So breastfeeding can really be just, referred to as nature's palate expander. And this is a research paper from UWA, published in 2007, I think, 2008. And until this paper was published, we actually didn't know how milk was removed from the breast. There was two theories. One was it compresses the nipple, and that's how the milk comes out. Or the other was actually that it comes out through vacuum. And so using ultra studies, this team in Perth were able to confirm that the milk comes out through vacuum. So what actually happens during breastfeeding is the tongue, it suctions up to the roof of the mouth, and then as it drops and lowers, it creates a vacuum, and that's when the milk is extracted. So that's how we describe breastfeeding as nature's palate expander, because we're getting that continual suction. And this is a really nice commentary paper. It connects all the dots with all different papers of evidence to suggest that, whether we choose to bottle feed or breastfeed a baby, it may have important implications on their jaw development and the development of sleep apnea 5, 10, 20, 50 years down the track. So that's a really great one. Now the problem in Australia is that the World Health Organization recommends that people breastfeed exclusively for the first 6 months of life, but only 15 mothers are doing so, and there are a number of, I hope it's not mine, is it? Yeah, okay, that's cool. Only 15 mothers do so, and there's a wide range of reasons, but two common reasons for premature cessation of breastfeeding are pain and the perception of low milk supply. So tongue ties can lead to both. We know that tongue ties can lead to pain and also poor milk supply. If a baby is not extracting the milk very well, later on as supply is regulated by demand and supply, if they're not extracting it, it'll be perceived as low demand, and then the supply will dwindle, and that's something that we see a lot. So I guess what I've gone into is that the ultimate goal of the tongue should be to actually help develop the palate and also stay suctioned to the roof of the mouth to promote better breathing for life. So what I'm going to do now is discuss tongue ties in infancy. So this is a good diagram, and what it's showing us is that in the first picture it's a normal tongue. The baby's got a good latch, their tongue can get under the nipple, and the posterior tongue is really free to raise and create that suction to extract the milk. And then if we go to the second picture, the tongue is tied, and the tongue can't really slide underneath the nipple. So anything that goes inside that baby's mouth is going to push the tongue backwards, and it's going to go into the back of the airway. They're going to break the seal more easily, they're going to gag. These babies can't take dummies. And they just don't have the elevation of the tongue to create that vacuum. So that's how tongue ties are a problem in breastfeeding. And one of the biggest controversies is really we don't really have a very good way of identifying which tongue ties are going to be problematic and which are based on appearance alone. So there are currently 2 validated screening tools to identify which tongue ties may be dysfunctional. One is the Hazel-Baker assessment. So there's 7 structural criteria, 5 structural criteria, 7 functional criteria. A lot of people are saying that this underdiagnoses tongue ties, but this is a validated tool that a lot of people are using. The other one is, so in Brazil, it's one of the first countries to pass a law that states that every baby should have their tongue assessed at birth, and it's an incredible thing that they've done because there's a country of 400 million So to get everyone on board is a massive job. And they use this screening protocol, which is called the Lingual Frenulum Protocol Score for Infants by maternal. And what they do, again, is they do scores as well. They ask a few questions about breastfeeding. Can you guys read that? Yeah. And then we have a look at their clinical examination. So I think these are really nice photos to look at. So depending on are the lips open or closed, they give it a score. What is the tongue looking like when it's crying? What is the shape? Then we sort of have a look at different things about the frenulum appearance, the thickness, where does it attach to the tongue, and then we give that a score as well. And then we ask questions about how they're sucking and what their function looks like as well. And then at the end of the day, we have a score, and if it's above this score, it's altered, and then we may need to consider releasing if there is any problems. So it looks like a pretty time-consuming thing, and the reality is that's not really what we're doing here. So what I do is, I think the infant and maternal symptoms are really important as a criteria for diagnosis. So what I have is just a functional history form, and we ask about the symptoms in the mother, the symptoms in the baby as well. And if we get like a high level of symptoms, that's probably something that's going to indicate I need to look at it more closely. But if it's low level, I'm probably not going to do anything. So these are the symptoms that we're kind of looking at babies. The babies are going to have a shallow latch, or unsustained latch. They're going to be nipple feeding. Remember, they can't put too many things inside their mouth because their tongue's getting pushed back. They're going to be gumming or chewing or clamping on the nipple. They'll have poor seal, clicking or smacking sounds. A lot of them will be swallowing air. They'll get excess gas, colic, reflux or vomiting. Because their tongue really can't elevate and create that suction, they're going to get tired really easily. They're going to be feeding more frequently or falling asleep at the breast more easily. Some are going to have poor weight gain and failure to thrive. Some are going to just get totally frustrated, bobbing on and off the breast. Some will have snoring, congestion or abnormal breathing, and they may be unable to hold a pacifier. In terms of the mother's symptoms, yeah, there's a lot of problems and issues with nipple trauma and that sort of thing as well. So we might get creasing or blanching of the nipples, and mothers will commonly report that it looks like a lipstick nipple, and I'll show you what that looks like in a moment. Crack, bruising, blistering, bleeding, pain on that. The baby's not really draining very well, so they may get mastitis and infection. They might get nipple infection, thrush with all the nipple damage. Really big is that they may have signs of guilt, exhaustion or depression, and I think that this is a really big thing in terms of tongue ties, because a lot of people are not really identifying them. They're saying there's a minor tie, it should be okay, and parents are persisting with these breastfeeding challenges, and it's really draining and exhausting. Premature weaning and the change in infant-mother relationship. So this is someone that she supplied me these photos with permission from the parents. But you know, here we have the mastitis, which is the build-up of the milk that can't be drained. We have cracking, bleeding, and the lipstick shape. So you can see how it's lipstick shaped. And really, mothers are really suffering, and a lot of them are being told that it's actually a normal thing for it to be painful, and really beyond the first few days it shouldn't be. So what else am I looking at? I'm actually looking at things like forking. So you can see that when the tongue tip looks like it has a heart-shaped indent, or when it looks like it's unusual, not the rounded tip, then that may be a sign that I'm looking at. And then we have the cupping or bowling, where we're looking at the baby's crying. Does their tongue look like it's, you know, the raised edges are free, but then it's tethered in the middle? So those are type of clues that we're looking at. And I'm also relying on what the lactation consultant may have said regarding the latch as well. And then another common thing that we see is milk remnant. So a milk remnant is when the milk is coated on the tongue, because the tongue can't suction and can't clear, so we see that milk remnant. And this is very different from thrush, because thrush can't be wiped away, and it tends to impact more of the mouth. So I see a lot of babies that come in and they've actually got this, and they're being treated for thrush. And I can't remember, I actually had a baby that was hospitalized from a reaction to the thrush medication. So I think that that's really important to be aware of. And then if you look at the lips, quite often when they can't create the vacuum, they're going to be squeezing tight with their lips or cheeks or whatever they can, and we can see this friction rub or the callus as well. So there are all the signs and clues that, hey, we might need to intervene. In terms of the appearance or where the attachment is, it's not something that, you know, if it's very obvious. So this is Kotlo, pediatric dentist. He made this classification up. So we have type 1 and 2 ties, you can see, are very close to the tip. And maybe they're the ones that maybe I'll be more inclined to intervene. But type 3 and 4, we call them posterior ties because they're a little bit more further back. They're going to restrict the back part of the tongue. And the type 4 is submucosal, so you can't even see, you almost have to stand and lift it up to actually visualize it. So we cannot actually suggest that these are tongue ties. Just based on the appearance, we have to look at the symptoms and how it's been functioning before we make a decision regarding it. And similar, he's got this classification with the lip tie. There's 4 different grades. It really doesn't tell me too much because, you know, with the tongue ties, there's varying degrees of elasticity and how restrictive it is, but it's just a communication tool more than anything. I really go by the symptoms and the function and what other colleagues are saying. And we actually have, these people did a research study on the superior level frenulum in newborns. What is normal? They photographed 100 and they got people to rate them. And what they've actually found is that it is actually very, very normal for babies to have this attachment that is quite high. And there is some research to suggest that some of it might actually recede, so it may go away. And really, we cannot make a decision to intervene based on the appearance of this. I actually get quite a few parents that are really concerned and they want to come in and they're worried about the potential for a future gap in between their teeth. And this is really not something that I'm concerned about at all because it is more appropriate for kids to have spaces in between their teeth, and we can actually address it later on if we need to. I'm more interested in, is this lip going to prevent a good flange so that they can seal onto the breast? And maybe then we'll consider if it's really tight, we may need to intervene. So these are some signs that, hey, it may be tight. So we can see that when I lift it, there's notching in the alveolus. And here you can actually see dimpling. I don't know if you can see on the top of the lip, there's this little hollow, and it kind of feels restricted as well. So we're going to go by what the lactation consultant says to a degree as well. The other thing that more and more people are becoming aware of is the impact of buccal or cheek ties. So this is one that I don't tend to release them very much at all. They're pretty quick to release, but actually it just prolongs the time that we're working on the baby. So with these buccal or cheek ties, if I lift the lip up and sometimes I can feel around the corners of the mouth it's really tight and we can't get a good seal, then I'll intervene. So I actually did this one. Yeah, so there's absolutely zero published evidence for it. Yeah, in theory, we want the lip to lift and seal so the baby can get a good deep latch. So this is probably the highest level, type of higher level study, which is actually a systematic review of the randomized control studies that have examined the impact of frenotomy or the tongue tie snip on breastfeeding, specifically the short-term improvements in the latch, and also the pain, the relief of pain. And what they've found pretty consistently is that it actually does help with pain and the latch. And one of the criticisms is we don't actually have any really good long-term follow-up of this. And one of the things that happens when you have these groups that are randomized into treatment and non-treatment, ultimately in all these studies, the group that's allocated to non-treatment, they actually decide to pursue the tongue tie release. So we actually lose the control group, and that's one of the limitations. So furthermore, this study actually suggests that it is very important to get good lactation support in conjunction with the tongue tie release, and also there is very minimal complications with this procedure, and there is some good improvement, so we need to consider it. And they are actually suggesting that everyone in the hospitals that is seeing those babies early be trained to identify this issue, because a lot of kids are getting missed in the system. Okay, so that's about breastfeeding. The other thing that I really want to highlight, which is really important to me, is infant reflux. Infant reflux is such a common condition amongst babies, where the contents of the stomach are spit out shortly after feeding. So these are some of the symptoms that they may experience. They may get stomach distension or a hard tummy, they're unable to lie down for long periods, constant pain, crying, irritability. These babies prefer to be held upright, they get congested in the morning, they're belching, vomiting, or have excessive gas. Okay, so when we have reflux, you know, a lot of people, they're thinking it's acid reflux. But the other thing that I think is important to rule out, which has very similar symptoms, is air-induced reflux. So tongue and lip tie can often lead to poor latch, and there's an inadequate seal around the breast and disorganized swallowing. So as a result, many babies swallow a lot of air, and they have these symptoms that resemble reflux. So I think it's very important to rule out prior to invasive testing and medicating infants. Because a lot of these babies they're getting under GA to get scoped to find out what's the issue. And we really need to ask about the latch. So in terms of evidence-based treatment for reflux, there's actually zero evidence for the effectiveness of these adult medications for use in infants. And I was just chatting with one of the school dads on the weekend, and we were talking about this, and he said, I'm seeing so many babies with infant reflux, and I'm giving them these medications, and they're not actually really working. So really, it's not really that evidence-based. But what we do have evidence for is that if we give these reflux medications to infants, there is an increased risk of bone fracture later on in childhood. So now, in terms of lip and tongue tie, what is the evidence that may help with reflux-like symptoms? This is a paper by an oral surgeon in New York, Dr. Scott Siegel, and he did a retrospective review of 1,000 infants that he had treated in private practice over a 5-year period, and he sort of included all the ones that were on proton pump inhibitors or H2 blockers. And what he found, I think these results very much shadow what we are finding with the babies that we're seeing on reflux medications, but approximately half of them had, at the 2-week mark I think it was, had improvement or complete reversal of symptoms or the cessation of medication. About 20% had improvement in symptoms, but they weren't successfully weaned off their medications, and 28% had no change. So his conclusion was there appears to be an association between air-induced reflux and lip and tongue tie, and these patients may be spared from more invasive studies and medications that have serious side effects. So we know there's more research required, but really if a child has reflux, we really do need to be asking about their latch. So I was really fortunate to actually get to go to his office totally unexpectedly last year. This is with Dr. A.L. Bolzer. He's a pediatric dentist that's published quite a few papers on tongue tie that I became good friends with, and then he said, look, I'm going to see Scott Siegel. So I jumped at the chance to see him because really this work is very inspirational to me. We see a lot of reflux babies, and the impact that it has on families because they're not really getting any answers. People are told they'll grow out of it. They're feeling very guilty because they're neglecting their other child while this other kid is suffering. People are trying all sorts of things to cut out foods from their diets. They're trying all sorts of different bottles, and really it has an impact across the whole family. So I think that one of the things that I'd really like to do in the future is raise more awareness amongst pediatricians. So I'm collecting case studies and hopefully can do better research later on. So in terms of case studies, I just wanted to show one particular case study because everyone thinks with a lip and tongue tie it's not going to affect the bottle-fed baby because it's so much easier, they don't need to use their tongue that effectively. But this is one baby, this is the pre-op, and I decided to do the lip and the tongue tie release, and this is the 1-week review. But this is some information about it. They came to me at 3 months because they had a tongue tie snip. So you can actually see on the bottom the scarring from the tongue tie previous release, so that was restrictive. So they had this tongue tie release at day 2, but they had persistent feeding issues. They'd always struggled to latch, feeding hourly, but poor weight gain. So she gave up breastfeeding in the week prior to me because the baby just couldn't transfer the milk even though she was able to pump very adequate amounts. They noticed clicking on the bottle, lots of swallowing of air, and gasiness and reflux-like symptoms. So they were actually taking Cadbury colic mix. So lots of the kids that we see are actually taking the pancreatic mix, which is supposedly to help their reflux. And he's never had a clean detach, so every time he stops feeding, there's lots of milk down the chin and neck. And they've seen an osteopath who noted tightening of the neck and tightness in diaphragm. So when I share a lot of the case studies, what I'm going to show you is, because I work with so many chiropractors, osteopaths, we can actually see that the tongue is not an isolated muscle. It actually is connected to the rest of the body, and we're learning more and more connections. So that's why I decided to put in things like this, because we're seeing some of the same things again and again. So I actually referred them to a speech and feeding specialist, asked them to work on the function in preparation for a release, and then 1 week after the tongue tie release, in combination with a speech feeding specialist and the osteopathic treatment, speech feeding specialist reported excellent tongue mobility. There was hardly any clicking on the bottle. We had a much happier baby, calmer, taking in less air, not spitting up, and rarely having access gas. Poos were mustard, not green, which is an indication that they're swallowing air. Feeding better suction, has moved down in teeth size. He doesn't get milk on his chin anymore. And the osteopath reports less tightness in the neck and facial muscles, and the diaphragm is now relaxed. So I can actually explain that, but I probably won't go into that today. And actually, I don't know if you can see, there's curdled milk at the 1 week review on the tongue. So I kind of mentioned to Mum, you know what, I'm seeing some curdling of milk. And she said to me, no problems, it's been a huge improvement. Before it was like Niagara Falls. She didn't actually know if it was worthwhile feeding her baby because everything would come up. And she just said, life is so much easier, I'm not having to do laundry all the time. So I think that this is really important work. So this is another baby, I thought I'd throw this in there. I saw her last week. She came in with a chipped tooth and she's 22 months old. And I saw her when she was an infant. And same thing, she was on low-sec medication. She was struggling to latch. Mum described the pain as toe-curdling pain. So we did a release and it actually helped, and she was able to get off the reflux meds. And 22 months later, she's actually still breastfeeding. Parents are very happy. So it's such a rewarding aspect of dentistry to be involved in. So posterior tongue ties. Previously all the research is about anterior, when we can see the obvious tongue tie. But what about those restrictions that are in the back part of the tongue? They're going to prevent the proper elevation and suction of the tongue. So Dr. Bobby Gahiri, he's an ENT, and he specializes in breastfeeding mechanics as well as laser release of these tongue ties. And this is his second paper to actually sort of pay more attention to posterior tongue tie. But what he did in this second paper, trying to replicate his first one, is he only used babies that have already had a tongue tie snip. So these babies have had a tongue tie snip, but they're having persistent problems. So then he's doing a subsequent revision to release the further back in the tongue. And they're 54 mother and baby pairs. And what he did, he measured the breastfeeding self-efficacy, so how confident parents are in breastfeeding. He measured it using a validated reflux symptoms screening scale, and also having a look at the pain. He checked it at 1 week and 1 month, and he actually found that these patients were actually improving. So what we know is that actually releasing the back part of the tongue can be very helpful, and we mustn't really overlook it if people have had a previous tongue tie snip. Dr. Gahiri, he asked me to help him organise a course in Australia because he wanted to teach, knowing a lot of the controversy. So next month in Melbourne, we're actually going to do something, and this is going to be a really great course for anyone that wants to learn more about tongue ties, specifically as they relate to infants more so. So how far do we go in terms of the release? So what I usually do is I try to go all the way back. So I try to release till I expose the genioglossus muscle because I want to free it up to work better. I really want that elevation or function. This is what it looks like immediately after, and this is what it looks like. I think this was a 1 week review, and we can see that the diamond shape and the yellow granulation tissue as well. So we really don't know exactly how far we can go. I think that one of the issues with the deeper releases is that the bigger the wound is, the more contraction there may be and the more risk of scarring there may be. So we really don't actually know, but I think we do want the tongue to lift in principle. So in terms of the release procedure, what I let all parents know, these are just some points. I say what I'm going to do is I'm going to release the anatomical restriction, but I'm actually not going to guarantee So babies have already been sucking and swallowing amniotic fluid in utero, and they're going to have certain patterns of compensation, and I don't expect that to change. So they need to work with a lactation consultant or a speech and feeding specialist to optimize the muscle function. And I also endorse body work, so whether it be chiro, physio, craniosacral therapist, someone who has worked with a lot of babies that have had tongue ties, because the tongue is actually connected to the rest of the body. So a lot of babies, you know, they've got tight necks or torticollis and they're feeding better on one side. We want to release all those strains to help get a better outcome. And if they've been compensating with other muscles to get that suction, we want to release everything. And it's very much like when we take that cast off the arm, we want to get everything fluid and mobile again. Because I've been involved with so many babies, and I listen to the parents, I believe this is an important part. And even though it's not evidence-based, I let the parents know what the rationale is, and many of them are on board to do this. I tell them that I'm not going to prevent future issues like speech issues, snoring, jaw development issues. Really what I'm working on is trying to improve the current symptoms. These babies have a functional deficit in their muscle development, and I think that it's going to catch up with many of them later down the track. So I say that, you know, if we have problems later, we'll deal with them later. Right now, if we can get better function, it's going to improve the trajectory of muscle development. The most significant risk is going to be reattachment or scarring. So it is normal in wound healing, for edges of a wound to join back together. So that's pretty normal if we don't change the pattern of function. So if I'm dealing with an older child or an adult, we do therapy before they even begin the release. We're getting them to learn how to use their muscles properly without compensation, but we don't really do that in children or in babies. So we just tell them to work out the breastfeeding, and we hope that that will change the pattern of movement. But the thing is, if you've had a tongue tie and your tongue's been tethered, you're not all of a sudden going to be able to suction your tongue, and it may take a few weeks to develop this tone. And it's those few weeks that everything is really reattaching tightly. So what I do is I endorse stretches 3 times a day to deliberately interfere with the wound healing and apply some light tension on the wound. They should only take a couple of seconds each, and this is considered sort of best practice amongst different people that are doing this. I think a lot of people are suggesting them more often, but I've actually found 3 times a day is okay. Yeah. So is tongue tie a fad? You know, last year there was this paper published which suggests there's been a very dramatic increase in the rate of frenotomy in children. So what they're saying is WA is actually worse. There's been a 530% increase in tongue tie release in this 10-year period. But when I really look at the numbers, it actually doesn't include the releases that are being done by dentists or the releases that are done in hospital. It's only what's covered by Medicare, so it's not fully accurate. But really, we're looking at it from 1.22 per thousand to 6.35 per thousand. We're looking at that from 0.12% to 0.6%, which actually I feel is an underdiagnosis. But at this time, this 10-year, it correlates with a 10-year dramatic or exponential increase in tongue tie research. So it's not surprising with this increased knowledge and increased awareness that actually has been an increase in the rates of frenotomy in children. So moving on now to tongue ties and issues with feeding on solids, we really have not very good research because it's really hard, especially when we're dealing with toddlers. There's no validated screening tool, so we really have nowhere to start the research from. So at the moment, the best available evidence would be case studies. So this is a case study, and I'm going to share it with you because I feel I learned a little bit from this one as well. So this patient presented to me at 13 months for tongue tie assessment. You can actually see when she's crying, that tongue's really tethered, it's not moving at all, and she's got a lot of drool on her face. So the tongue tie was identified by a lactation consultant who referred them for a laser release. But at that time, the laser release provider, they actually had their own lactation consultant who was double screening everyone that came into their practice, and that lactation consultant said, don't worry about the release, it's not really necessary. So the mum was sent away, and actually she still had breastfeeding issues. So she expressed milk for about 6 more weeks, but then she just decided to give up. It was way too difficult, so she went on to formula. Then they saw a chiropractor because the girl has inward turning feet. So it sounds a bit strange, but actually we're seeing a lot of connection regarding this. And so they came along to me, and you know what she's saying to me? I don't really have any problems with this tongue tie. I just want to see what are the implications for the future and what should I know about it. So I start asking a few other questions, and what I also notice is she's got excessive drooling, no perceived concerns with EV solids. She's a heavy mouth breather, and she's got effortful breathing during sleep. So she's restless, she's hot, her hair's soaked and matted on her face. So we know that she's got some degree probably of sleep disturbed breathing. I knew it was tight, but I'm not going to make a call. So I actually said, go and see this speech and feeding therapist and get her to observe a feed and see what she says. And then the speech and feeding therapist said, actually this girl, she can't move her tongue. She's actually not chewing really well at all. So I think it will be a benefit to release this tongue. And she did some prep work to get the patient ready. So what happened? We did the release at 16 months in combination with the feeding specialist work and the chiropractic treatment. And at the 1 week procedure, she could now say 5 new words, which is pretty remarkable to her family. She was saying things like shoes, shower, her pronunciation had got better, her drooling had gone down, so it used to be constant. They always had to change her bib, and she had the same bib on for 3 hours, which was pretty exciting for mum. And what they noticed is that she was eating differently. So the daycare had said, hey, she ate Weet-Bix with her spoon. And the mum was really surprised because really every time she was eating, she's actually putting her fingers in her mouth to move the food around. And she didn't actually know that that was not normal for children to do that. So that's what I've learned. I've actually learned how important it is for the tongue to be able to move side to side for chewing. And it's something that I now ask parents, you know, about their history, whether they're using their fingers. And so grooming has become less effortful and being through the nose. So, you know, as I mentioned before, if we can promote the tongue to go up, they're blocking off that oral airway, they're going to probably have greater chance of nasal breathing. So what about tongue ties in speech? Again, there's not a huge amount of research regarding this. I think two of the most important people would be Carmen Fernando. She's a speech pathologist. She's passed away, but she wrote this book, Tongue Tie from Confusion to Clarity, and she actually documented that people that had the tongue tie and that had the revision and had the speech therapy, they were seen to get good improvements in it. And the other one that is really important is Irene Marcassani. She's a speech and myofunctional therapist from Brazil, one of the leading researchers in the leading country for myofunctional therapy research. And she actually found that we can expect that if you have an altered lingual frenulum, you're going to have a 50% chance of a speech disturbance. So interestingly, even though this was published in 2004, the system that she used to assess the tongue mobility has now been validated. So because we don't have research, I'm going to suggest, and case studies are the lowest form that we need to build upon. I'm going to share 2 case studies, one regarding speech delay. So we know that there is actually research to show that the free tongue is very important in speech perception and speech development. So for instance, if a baby has a dummy, they're going to be at more risk of developing that speech delay, and same thing for a tongue tie. So this was one of the most rewarding cases that I've been involved in, and really life-changing. So the parents actually came because they had concerns regarding the speech delay. He wasn't talking, or if he said a word, he would lose that word. And actually, at this time, I had done 16-month old, and I wasn't game on doing toddlers. And so somehow this slipped through the cracks, and which was probably not a bad thing. But he's already had his tongue tie cut with scissors at birth, and you can see there's a clear restriction there. So they breastfed for 16 months, but they had to use a nipple shield, you know, to improve the latch and actually, you know, make sure it wasn't painful. And they, in the history, he's had a regression of eating, so he's not eating very much. And what I found that made me really want to help this family is this kid is super irritable and frustrated. So the whole consult, he's on edge, and I'm on edge, and everyone else is on edge. He's really finding it hard to cope with. These parents are totally struggling. So I said, I'll go and see this speech pathologist and see what she says. And the speech pathologist actually said, Shereen, I suspect this child is on the spectrum. So she works in a hospital, and she has a lot of contact with the pediatricians, and she was wanting to go down that kind of path. But I said, you know what, he's got a severe restriction. Let's see what we can sort out, and then you can do whatever you want after. So we decided we're going to get speech pathologist to actually work on the muscle function in preparation for the release, going to refer him to a chiropractor because he's had a traumatic birth. He had his cord wrapped around his neck. It was vacuum extraction, so there's going to be some issue there. And then this is what happened at the 1 week review. They said he's like making lots of sounds. He's copying everything that he hears on TV. The speech pathologist and they have noticed that he's chewing more with his mouth closed. He's using the back of his tongue more, and he's moving it more effectively side to side. But one big thing that his dad said is he learned how to say the word no. So now, instead of getting frustrated, he can actually communicate no. And it's actually changed his whole personality. So this kid that we thought, well, the speech pathologist thought was actually autistic, just actually really had a hard time communicating. Even looking at the child, it was very calming, and he was a totally different kid. So I was actually supposed to go out for dinner that night with some friends, and actually I was just so happy. I was actually late for dinner because I was just like feeling really proud to be involved with this particular case. And these parents have become very big advocates for us. They don't think that it's the tongue-tie release. They think it's a combination of the tongue-tie release, the speech, and the chiropractic treatment. And I believe so as well. So now I think it's about, I don't know how many months he's out, but he's actually discharged from speech pathology. They were concerned about his delay, but now he's actually on the high end of vocab for his age group. So that's a really great case. The other one is a speech articulation issue. So if we have a tongue restriction, we're going to expect that they're not going to be able to articulate very well. And so this is a 4-year-old. His kindy teacher said, we're having problems understanding him, so why don't you take him to a speech pathologist? And he was actually seeing an osteopath at the time, and the osteopath said, he's got a heart-shaped tip on his tongue, so why don't you actually go and see Shereen for an assessment? And so I saw him, I'm taking the history, his parents are telling me it's difficult for people to understand him. He's not a really great sleeper, I'm finding out. They're not coming in there, but I always ask about that. His teeth grinding, he's got wet nappies, restless sleeping, and very difficult to fall asleep. So we know that, I'm thinking that he's got some sort of form of sleep disorder breathing. So you can see from the before and after pics. So this is the one, so we've had the before pics. You can see when he elevates his tongue to the roof of the mouth, can you tell that he's really straining there? And then this is the 1 week pics as well. So his face looks a lot more relaxed. Okay, so what we decided with this kid anyway, before we jump into the release, is we're going to do some myofunctional therapy. And in our practice, we also do some myofunctional therapy. We have a couple of therapists, including Rachel over there, and we don't really work on really, really young kids. So 4 was the youngest child that we worked on, but I said, look, let's do this, because a lot of the kids, when they do the myofunctional therapy, the parents will report that their articulation is much better. So just doing the tongue exercises, his teacher said there's been a phenomenal improvement in his pronunciation, and parents were so happy because every time they had family members and friends come over, they're saying, oh wow, he's speaking so clearly. I'm really reluctant to go in on a 4-year-old. It was actually the youngest kid that I kind of treated in a chair with cooperation. And I said, let's just delay it. If you're happy with the speech, let's just delay it. And Dad said, yeah, okay. But then all of a sudden I found him in my book, and I had to do this release. His mum had said, look, I think let's give him the best chance of confidence to get this release done. So 2 months after release, these are the findings. He's got increased confidence, he's reading aloud more, talks more, stories are more elaborate, with bigger words, no teeth grinding during sleep. There's restlessness, doesn't take as long to fall asleep, so it used to be 45 minutes and he's sleeping a lot longer. No more wet nappies, eating more. His osteopath reports his feet are no longer turning, and there are no more issues with hip alignment. A lot of people coming in for one problem, but we're actually finding that maybe it's improving their breathing and other different postural issues as well. So moving on to tongue-tie and sleep apnea. This is the first research paper published that identified that tongue-tie could be a risk factor for obstructive sleep apnea with Dr. Krishy Gimeno. And what he did is he did a retrospective review of some of the children with the tongue-tie, and really it was the tongue-tie all the way to the tip of the tongue. And at the time when he was doing the plans, the children were referred for adenotonsillectomy, palate expansion, tongue-tie release, and myofunctional therapy or exercises to promote normal function. And some kids did all and none, and whatever they did, when they followed that up with sleep study, there was always some improvement. But you could not get normal breathing, which is 90% or more nasal breathing through the night, until you actually did the myofunctional therapy or taught the child the tongue exercises to keep their tongue up and to breathe through their nose and close their mouth. So this was the research, and then people started looking at it. This is the next paper that was published on tongue tie and sleep apnea, also with Brist and Guilleminault in the European Respiratory Journal. And what they did was they found 150 consecutive children that had been referred to this clinic with sleep disordered breathing, and they sort of managed to find that there was two clusters of kids, so one that had the enlarged tonsils and the other that had the lingual frenulum, the tongue tie. And this is actually a specialist clinic, so they're getting the more severe cases or more confusing cases. So some of these kids that had the tongue tie had already had their adenoids and tonsils removed. And what they found is that if the kids in the tongue tie group were going to be the ones that had the narrowing of the palate, they had more narrow palates. So they concluded that if you leave a shortened lingual frenulum untreated at birth, it is associated with development of sleep apnea later in life due to the abnormal function. So if we look at the kids that had the tongue tie, out of the 63, 41 had problems with speech and feeding, so none of them actually really knew that they had tongue tie. So there may have been some dysfunction associated with it. Now, I don't think this study is really that perfect, but what it actually showed us is that we need to examine this relationship with the tongue tie and sleep apnea more closely. So the next step to do that is we need to validate a way to assess tongue ties. So again, this is by Audrey Yu, Stanley Lewis, Rishadi, Christian Guilleminault, those guys. Audrey Yu did it in her private practice. She got 1,052 patients, and she took all different types of measurements of the tongue. So we looked at if you put the tongue to the papilla, how far can you open incisally? What is the maximum incisal opening? And then what is the length of the free tongue? And so they looked at it, and they found that there was only one measurement that had a normal distribution. And this is actually a ratio. So if we look at what is the ratio between the tongue opening, between the incisal opening when they've got their tongue on the tip to when they've got the maximum. So that's what we look at, the ratio. And so what they found was because it was normally distributed, we could make it up into 4 classifications from grade 1 to grade 4. So the grade 1 is when the tongue can, the distance is about 80%, and these people are in the top 10%. So we have this way of assessing tongue restriction. Yeah, okay. So the next study from them is actually, now that we have a proper way of developing it, they did this study. They had a look at 302 consecutive patients, again in Dr. Audrey Yun's practice, and they tried to take all sorts of measurements. And do you know, I'm going to try and play the video and just give myself a little bit of a break. It is a 3-minute video, but this was quite impactful. They were actually asked to make a video abstract. So let's see if it works.
We eat and speak with them, but our tongues may be even more important than we think. In a condition called onchoglossia, also known as tongue tie, the tongue is tethered more tightly than normal to the bottom of the mouth by the lingual frenulum. While this is usually considered relatively harmless, new work from dental and sleep experts at UCLA and Stanford suggests tongue mobility is critical for proper development of the jaw and facial tissues. In the study, researchers evaluated tongue mobility in 302 patients using the tongue range of motion ratio and the Kotlow free tongue measurement. All measurements were performed in triplicate to ensure consistency and accuracy. Each participant also had dental casts made and x-rays taken to capture anatomical features of the teeth, mouth, and face. Most people had normal or only slightly diminished tongue ranges, although some had more severe restrictions. Reduced tongue mobility correlated with a smaller ratio between the inner canine width and the canine arch length, which may indicate underdevelopment of the upper jaw. Limited tongue movement was also linked to having longer soft tissues at the back and roof of the mouth. Longer soft palates are common in people with obstructive sleep apnea. It's possible that people with reduced tongue mobility may breathe with their mouths open more or swallow abnormally, which may help elongate the soft palate. The longer soft palate could also arise from reduced tension holding up the soft palate due to narrower maxilla. Contrary to previous suggestions, however, no association was found between ankyloglossia and position of the hyoid bone, a horseshoe-shaped bone in the neck that moves with swallowing, chewing, and breathing. The group also found no relationship between decreased tongue mobility and the classification of malocclusion, which 2 small studies previously reported. But the lack of evidence for these associations doesn't mean they don't exist. While this study is one of the largest of its kind overall, there were few volunteers with severely restricted tongue mobility or with abnormally aligned teeth, which may limit some of the findings. Nevertheless, the results do suggest the tongue plays an important role in development of the mouth and face, and if the tongue cannot move freely enough, people risk developing high-arched palates, a narrow upper jaw, and longer soft palates.
Okay, so what this is showing us is there seems to be an association. There seems to be an association with tongue tie and narrow palates. But this is really no evidence for us to intervene. We don't really have evidence that we need to intervene to prevent these issues. But from a breathing perspective, the rationale can be best validated with the evidence in support of myofunctional therapy. So myofunctional therapy is exercises to actually retrain correct function of chewing, swallowing, speaking, promoting nasal breathing. Really what the aims are is to get the tongue sucked into the roof of the mouth, nasal breathing, mouth closed, and we're going to at the same time strengthen the muscles of the pharyngeal dilating muscles so that we can reduce the collapsibility of the airway. And so this is a meta-analysis which actually shows that we can actually, in adults, in a large pool of patients, in adults we can actually reduce obstructive sleep apnea by 50% and in children by 62%. So it's very, it's useful as an adjunct to other frontline treatments. And really in the field of sleep medicine and sleep surgery, there's a lot of research being done on it because we know that we don't have any one treatment that is successful and we need to consider combinations. So when we do this myofunctional therapy, if we can't get the tongue to palate seal, if we want to try and get that as a goal, we need to have an unrestricted tongue. So yeah, that's the rationale for it. And at the moment, there's very little evidence. This is the first published case report to support that, to show us that when we do myofunctional therapy in combination with tongue tie release, we can actually get better breathing and reduction in snoring. So this was actually a case report from Dr. Surusaki, and it's actually on a 3-year-old patient. But what I think I'll do is I'll just skip through one of our own because we have a few of our own patients. This is a 13-month-old child, and really when they came in, all they're coming in with, they're aware they've got a tongue tie, and he just wants to do something about it because, you know, he eats ice cream and it's really embarrassing for him because he's getting it all over his face and his friends don't tell him and he's walking around with ice cream all day. But during the functional history, I found out that he's got difficulty falling asleep. He has constant nasal congestion, teeth grinding. So what we do is we do the therapy to prepare the tongue. We try to get a better tone so they can do the right thing after the surgery. And then after 10 weeks of this with the myofunctional therapy, and I actually used a myofunctional device that he wore for 1 hour a day and during the sleep to put the tongue up. He said that he was able to breathe easy through his nose. He was easy to fall asleep with less nasal congestion. No longer waking at night with dry mouth, no longer aware of teeth grinding. Ice cream is easier, and he's saying, I can lick my lips now. I never knew that was possible before. And then I speak to his mum, and his mum says, do you know what? He used to have these headaches with nausea that actually kept him away from school, and he had them about once a month. And so at 10 weeks, I'm thinking, okay, let's just see if that's coincidental or anything. And then we just called him last week, and I think maybe he had one headache without nausea. So yeah, it's actually busted, and I'm really not that surprised because we're getting a lot of results like that. So as I mentioned, case studies are the lowest form of evidence, and then once we've got a few of them, the next thing is the case series. So this is an unpublished study, and it is due for publication by Shereen. And what he's done, yeah, quite a few of you guys probably, you know, came to see him last year in Gold Coast, because I actually organised a course, but I've just learned so much about tongue-tie release in combination with myofunctional therapy from him, and I'd highly recommend him. But yeah, he has 420 patients that had the tongue-tie surgery as an adjunct to help improve the outcomes for myofunctional therapy. They may have been presented with mouth breathing, snoring, low tongue posture, tongue thrust, bruxism, swallowing issues, and cervical facial tension. And so 348 of them participated in this study. And so, yeah, I think I actually deleted that. But it just goes through the... It shows, what you found is that there was a 91% success rate in terms of the satisfaction, and many of them had an improvement in the quality of life. He went through all the complications there, and you can kind of have a look at it clearly, but I think these case series are really important to learn more about what we need to look out for. And I think ever since we've done the course and really focused on the myofunctional therapy in preparation, we've just been getting better and better releases. So that'll be really interesting when it gets published. But out of 2 patients in that study, they actually had poorer outcomes. And so what he actually suggests is when the patient can't get this good palatal suction because their mouth is too constricted, I think this patient may have had some premolars removed. Actually, that is not a good candidate for doing the myofunctional therapy and actually the tongue-tie release. So that's something that we need to bear in mind. And at the sleep surgery conference, I know there is currently data that actually is collected that shows these patients with high arch palates are really not great candidates for myofunctional therapy. So Dr. Shereen, he's taken this functional classification a step further, and he's actually looking at, okay, what's happening when the tongue is suctioned, and what are the various compensations that can occur if we have a tongue restriction. So what I'm going to just show you is a few little compensations that you can be aware of when we have a tongue tie. So this is a kid that, actually I can't remember why he came, but he didn't come in for, anyway, he has a tongue tie, very, very severe tongue tie. And so I asked him to lift it, and you can actually see he's straining all his neck. And during the history, I found out that he's got this neck pain, and if he doesn't see the osteopath on a regular basis, he's really suffering. So I just did the release for him. Yeah, thanks, Carly. I don't know. Yeah, so I just did the release. Was that a message regarding him?
That's what he came in for.
Okay, yeah, okay. Thanks, Carly. Sorry. Yeah, so I just did the release for him a couple of weeks ago. I haven't actually seen it. You guys have seen him. So it'll be really interesting to find out what's going to happen with this neck pain, but I'm predicting that it will help based upon our experience with previous patients. And I didn't even do a full release. I kind of had to stop before I really wanted to, because when I did the release, he was so disconcerted that all of a sudden he had this tongue in his mouth, and so I kind of just stopped it there because I already wanted to prepare him. I think you might need more than one release. Because if the tongue is not really towed, there's no real point to release all the way back. And yeah, so it will be interesting. But what I did, because you know I've been telling you about his inward turning feet, when I was on the chair I noticed, oh, his feet are turning in. So I'm actually going to follow that up next time as well, because I'm curious. Now the other thing that we see is jaw compensation.
Can you just stick your tongue?
Oh, sorry. So some people will actually compensate for their restriction with their
Can you just stick your tongue forward as far as it can go? And
so he's really straining his jaw and moving his jaw to
and tongue open wide, and stick your tongue up. Point it up to the roof. Okay.
You can see the dimpling where his tongue is tethered. He's really going to struggle to have good tongue to palate seal. Yeah, so the funny thing is he actually came in without realising he has a tongue tie. He actually came in because the mum's thinking he has a lip tie, and he's actually got a gap between his teeth, and it's a pretty age-appropriate gap, and the lip tie is really the least of his concerns. They have no perception of any problems. But I'm going through the history and I'm asking about the feeding and speech and everything, and the mum is saying meal times in our house are a nightmare. It takes an hour. He's really picky with his food. He's always pouching his food. it gives her a lot of grief. So we're actually going to proceed with myofunctional therapy and tongue-tie release for this patient. The other thing that I just decided the other day, I'm going to take a picture of one of my dental assistants. So we're looking at the tongue range of motion. What's her maximum internal incisal opening? It's 40 millimeters, and then I look, it's 26 millimeters to the tongue tip. But actually what she's doing when she raises her tongue, she's going like this. And so she's actually kind of moving her whole head. So the posterior part of her tongue is actually restricted. And so if I ask her to just move her tongue, don't move anything else, and I try to take that measurement, it's actually 15 millimeters opening. So what she actually has is she has a grade 3 tongue mobility, but she's compensating to grade 2. So we look at her palate, lingual to palate suction. And what you can see in the first picture, this is her. She can't do that without elevating the entire floor of her mouth. So what's going to happen during sleep? When all the muscles are relaxed, she's not really going to be having good tongue to palate suction or good breathing, but she's not really having any problems, so we're not going to address that. But you can see in contrast, this is Carly, our practice manager. She has a fantastic tongue, and all our patients really comment. When she gets that seal, you can actually see the caves. So she's got some good suction there. But what's the problem with the back of the tongue can't elevate, right? So over time, with disuse, we develop really low tone, and really it's the intrinsic tone of our tongue that matters when you're sleeping. So here we can kind of see, this is optimal tongue posture where the tongue is up, suction to the roof of the mouth, and here, when the tongue is postured low and low tone, it's more likely to encroach in the posterior airway space and be sucked in when the pharynx collapses and causes blockage. So posterior tongue tie, even though it's not really easy to pick up with that grading scale that I showed you before, we need to kind of look at that as well. So this is a case study I'm going to show you with the posterior tongue tie. So this is a patient, he was actually referred by actually my husband Alex with teeth grinding. He was aware that teeth grinding, many of you might know that it could be a sign of obstructive breathing, because what these patients are doing is they're moving their lower jaw back and forth. This is actually bringing their genioglossus forward to help clear the airway when there's going to be a collapse. So I actually am not a really big fan of doing occlusal splints because we know that can aggravate the sleep disorder breathing in some patients. So what I said to him was, why don't you do a sleep study? Because he had lots of fatigue. And so I said, why don't you do a sleep study, find out what's the issue. But at the same time, you have this tongue tie, and that may be impacting. And if you can do some therapy to get the tongue up in the roof of your mouth, that can be an adjunct to any frontline treatment that you have if you have obstructed breathing. So he went away, and actually he couldn't really commit to the sleep study. But then he started to get more pain from the bruxism, and then he was actually really bothered by his tongue, because since I identified it, he actually realized that, hey, my wife can move my tongue better than me, and I've got a problem with my tongue. And so he's been practicing on his own through the internet or whatever, how to put your tongue up and all that type of thing as well. So in the history, what else did I find? He'd wake in the morning with sore and swollen jaws, had nasal congestion, found it difficult to breathe, so when he's elevating, he's actually compensating with the use of his neck and his jaw muscles when he's creating that suction. So I actually, we did the myofunctional therapy, and we referred him to a craniosacral therapist who's also a physiotherapist, so she has that, and she did work with him. And she had said pre-release, he was super tight, he just couldn't really relax. His sympathetic nervous system was highly charged. So within hours, this is what he says to me: my tongue is able to rest easily in the roof of my mouth compared to having to strain before. He's less congested. Within hours, he's able to breathe more easily. And so on the evening of the surgery the next morning, he actually noticed less tension, and he was actually more flexible in the shower. He realized for the first time he could actually sort of like reach around the back of his neck. And so the craniosacral therapist actually noticed there was a dramatic reduction in the sympathetic nervous system and some reorganizing of all the different muscles. So they give me the feedback, which is where I learned from. And overall, there's less tension. And so what he actually found in the first week, that he actually told me that his digestion has improved and he's getting better bowel movements. And his symptoms had previously been similar to irritable bowel. we know that if your sympathetic nervous system is in overdrive, your rest and digest is actually not working as well. So it kind of correlates. I actually really have no idea, exactly why it works, but I think this is really interesting. So he actually found that there's got less muscle pain, so he feels that he's not bruxing as well. And so I think now we've reviewed him for more than 2 months, he actually reports all the improvements have helped. So it's really made a pretty good impact on his quality of life. So what role does, what is the link between tongue tie and postural things? Actually, there is research. I'm no expert in this, but actually I go to quite a few international conferences of myofunctional therapy, and this is where I learned, because I think the Italians are really good at the research on tongue tie and posture, but there are postural implications. And there is a couple of papers in English that actually show the postural patterns that people will have, that they've observed with people with tongue tie. And I've discussed about inward turning feet and all these diaphragm relaxing, and really the tongue is actually connected to the rest of the body through connective tissue called fascia. It's only been recently discovered the significance. Previously it was thought to be like all the packing between all the muscles and the blood vessels and all our organs. But there's a very important thing of fascia, band of fascia that surrounds all these structures. From the tongue right down to the toes. And so the fascia is kind of like a really tight stocking, and if we have pinched in one area, it's actually going to affect that whole thing, that whole line of fascia. And so this is the reason why I think that we are noticing these important, these postural implications. So I think this is the end, but what I thought I'd finish off with is just one case study of a patient with chronic head and neck tension, because actually we're dealing with a lot of patients that have these chronic head and neck problems and migraines, and they've had MRIs and they're trying all sorts of different things, trigger point injection, prolotherapy, all these different things that they're not having any resolution with. So she has a posterior tongue tie, and this is the before and 1 week after. So actually we can see that all of a sudden she's straightened up a little bit. And this is, because I've found out about these postural implications, I'm always taking photos before and after. And I'm seeing it fairly consistently where people sort of stand a little bit more upright after the release. So she came in and she had less headache. She came in with these chronic headaches, and she was taking migraine medication and she's having a real struggle with this headache. So she just wanted to see if I could help. And what I decided was, because when she's moving her tongue, she's actually it's triggering, it's creating this problem in her neck, and it's triggering the same pattern of pain that she's getting the headache. So I thought, okay, maybe this will work, but I can't guarantee it. But let's try this myofunctional therapy. So she's had myofunctional therapy in combination with osteopathic treatment. And this is the 8-week interview that I did with her. She's getting less headache. So instead of taking Panadol 5 days a week, she's only taking it 1. She's getting more neck flexion. She doesn't feel like she has so much neck tension, which is what was actually triggering her headaches. She still has hormonal headaches on a monthly basis, which she feels is kind of expected, and she's not getting to go off the preventive medication for her migraines. She previously felt like she had a swollen tongue, like it had been stung by a bee. And what she said was really interesting was, regardless, I've had these really good improvements in my pain, but even if I didn't, the freedom to move my tongue would have been worth it alone, because now I can actually move my tongue and I can clear food from my mouth, and I actually didn't know that was possible. So overall, she's very happy with the experience, and she wants her 22-year-old son to look into this. So that was my last case study. Really what I wanted to share with you is that it is controversial because we don't have the evidence for it, but what we're doing is we need to look at these case studies and actually learn from them, and that's, what I do is I find out from other different professions, and that's where I'm learning the most. And I think the ultimate goal for the tongue should be to actually suction to the roof of the mouth And if we don't, we're going to get these compensation patterns that are going to actually contribute to other sort of symptoms. And what I really would like people to be aware of, whether it's breastfeeding, infant reflux, or any other issue, is to be able to consider tongue restriction in the differential diagnosis of these problems, so that we may be able to help people. All right, so thanks very much, everyone, for your attention. I'm really happy for everyone to email, but I'm also happy to take any questions. It is a controversial area, and I'm ready to take on anything that you want to. Yeah. Yes. No, I haven't done any in GA at the moment, so I've done up to 2 years. I think we've done 2 years. I'm kind of comfortable with that because actually it's such a quick procedure and they get over it pretty quickly. It's within seconds. I think they're most distressed when they're getting actually restrained. And then from 2 to 4, I haven't done, and I'm a bit more worried about doing it, but I see the impact that it can have on families, and perhaps I will consider it. Yeah, and then 4 and upwards we've done. Yeah.
You do it with scissors or with laser?
We use a laser, so I feel, I'm not confident with scissors, but laser has good hemostasis, and this means we can be fairly precise because of the visibility, and I can just go bit by bit by bit, and I feel pretty comfortable with the laser. Yeah. Yeah. Did you? Okay. Yeah. All right.
During my own study, there was a football coach who insisted, or who players have the tongue part because it affects their breathing and their posture.
Hopefully I've been able to demonstrate that. Yes, I believe that it does impact their breathing and their ability to get that suction, which is important for good nasal breathing. And yeah, posturally, there's so much to learn, but we're seeing it. So yeah, actually, let's see. Yeah, there is actually some good research to suggest that we need to put the tongue on the incisive papilla. It's actually really important. It's an area that's really rich in sensory receptors, and if we put our tongue on this spot, it releases. It's involved in neurotransmission. It releases hormones that are involved with balance. This is Italian research. I was really lucky to hear this Italian guy. I can't remember his name. It was probably one of his only English, Antonio Ferrante, sorry, yeah, one of his only English lectures. But he's actually done like 4 textbooks on myofunctional therapy. So he's done really amazing work where you get the tongue to go on the spot. Like I saw the videos where he's got Parkinson's people and he's improving their balance. So yeah, I believe, I don't know enough about it, but yeah, definitely I'm very open to the possibility that, yeah, we need to get the tongue up to help. Yeah. Okay, cool. Thank you very much, guys. Yeah.